Yeah, good afternoon.
Yeah.
Apologize for the froggy voice of getting over something, so I quickly say some welcome comments and then turn the program over to Deborah Matthews. For those who don't know me, I'm Jeffrey Kahn. I'm the director of the Berman Institute of Bioethics here at Johns Hopkins, and it's my pleasure to offer a few welcoming remarks to the 2026 Carlton Haywood Jr. Memorial Symposium. We're honored to have the opportunity again this year to co-sponsor this event with the Division of Hematology in the School of Medicine. This symposium represents an effort to honor and remember Carlton's legacy as a scholar, remember him as a colleague, and for many here today, and all those who we touched, to remember him as a friend. Carlton's work reminds us to listen to patients, to understand them as people and not merely as a diagnosis or an illness. He reminds us that patients are partners in their care and that trust in professionals is critical and requires understanding what it takes to build it and maintain it. We remember Carlton today on the occasion of the symposium named in his honor, and I ask that you keep his memory in your thoughts today, remembering his, and this is a quote from one of the many memorials, on his passing, his brilliance, generosity, kindness, compassion, and humility. And I hope that we all honor his memory by recalling his work, his friendships, and the mark he left during his altogether too short time in this world. Thank you all for being here, especially to the family and friends and colleagues and participating in today's symposium. And with that, I'll turn it over to Jeff to introduce today's program.
Thank you very much. I'm Deborah Matthews. I'm faculty in the Berman Institute of Bioethics in the Department of Genetic Medicine, and I chair the Carlton Haywood Symposium Committee. Thank you all again for being with us today to honor the life and legacy of Dr. Carlton Haywood Jr. I also want to say a special welcome to Carlton's family who's traveled to be with us today. A dear friend and colleague of Dr. Haywood's, Mary Catherine Beach, unfortunately is not able to be in the room with us today. She's also a member of the Haywood Symposium Committee. And I want to read her remarks from that she drafted when we first started the symposium regarding Carlton's life and legacy. Dr. Carlton Haywood Jr. was a leader in sickle cell disease clinical research in bioethics who died on December 31st, 2021 at the age of 46. In his short but impactful career, Dr. Haywood's distinguished scholarship and advocacy challenged the medical community to address significant injustices and deficiencies in the care of people with sickle cell disease. Carlton was born in Atlanta, Georgia in 1976. A serious and ambitious student, he earned undergraduate admission to the University of Virginia, where he found his calling as a bioethicist. Dr. Haywood graduated from UVA in 1999 with a bachelor's degree in religious studies and bioethics, and in 2003 with a master's degree in bioethics. Keen to pursue his doctoral studies in bioethics, Carlton came to Johns Hopkins University and in 2008 graduated with a PhD in health policy and bioethics. Upon graduation, he joined the Johns Hopkins University faculty in the Division of Hematology and the Berman Institute of Bioethics. I'll add a personal note, that's about the time I joined the Berman Institute. So as far as I was concerned, Carlton was, like he had always been at the Berman Institute. And was sort of part of my personal experience of the place as well. Dr. Haywood was a unique and creative scholar who had both talent and tenacity to lead impactful, internationally recognized research on the medical condition with which he lived. His scholarship highlighted issues of injustice and paved the way for improving the overall quality of care for those with cell disease. Dr. Haywood worked generously as a mentor to numerous students, trainees, and junior faculty, both at Hopkins and beyond. Dr. Haywood's service to the sickle cell disease community was also quite extensive. He served on numerous local, regional, and national advisory committees convened to solicit expert guidance on sickle cell disease-focused initiatives. Dr. Haywood was an active speaker at the national level. He frequently gave guest lectures in academic courses and grand rounds at universities and medical schools across the country, and was also a highly sought-after speaker for workshops, seminars, and conferences that focused on sickle cell disease research and advocacy. Among the many awards and honors that Dr. Haywood achieved was his 2009 inclusion in the Alpha chapter of the Delta Omega Public Health Honor Society, and his recognition by the Ebony Magazine editorial team as one of the 100 most influential African Americans in the country who were so honored for, quote, changing the course of history and making an enduring and lasting impact on their communities and the world. That he was a brilliant scholar is clear, but Carlton was also resilient, generous, patient, and kind. Under almost any circumstance, he had faith and saw the best in people. He had a fierce love for his friends and especially his family. Dr. Haywood's early death reminds us of the urgent need to address the profound and persistent suffering that gravely limits the lives of so many people living with sickle cell disease. Dr. Haywood envisioned a world that honors the human dignity of each person living with sickle cell disease and provides those persons with appropriate and timely treatment. Although his presence is missed, his vision continues to illuminate the path ahead. All right, it is my honor and delight to introduce our keynote speaker for today, Vence Bonham. Mr. Vence Bonham Jr. is professor and founding director of the Center for Bioethics, Social and Behavioral Research at Meharry Medical College in Nashville, Tennessee. He's also president and CEO of the Diaspora Human Genomics Institute, a nonprofit organization dedicated to advancing human health through genomics and education, with a commitment to the inclusion of individuals of African ancestry. Professor Bonham joined Meharry Medical College with a background that spans law, bioethics, and genomics. He's held multiple leadership roles at the National Institutes of Health, including Deputy Director of the National Human Genome Research Institute. Prior to his appointment as Deputy Director, he was the Senior Advisor on Genomics and Health Disparities. Mr. Bonham was a faculty member in the Intramural Research Program at NHGRI. His work focused on the societal implications of genomics, health equity, and bioethics. He was a key figure in national discussions of the use of population descriptors in genomics research, leading policy development for NIH. He earned his JD from the Ohio State University Moritz College of Law and a BA with honors from Michigan State University. He held a tenured faculty appointment in the College of Human Medicine at Michigan State University, and later was an adjunct faculty member at the St. Louis University School of Law while at NIH. Prior to these academic roles, he worked as legal counsel in higher education. In addition to his administrative leadership, Professor Bonham has authored over 100 peer-reviewed publications and received numerous accolades for his contributions to science and education. Notable awards include the Advocacy Award from the American Society of Human Genetics and Outstanding Faculty Mentorship Award from NHGRI. His commitment to mentorship has empowered many trainees, guiding them into successful careers in medicine, law, and bioethics. And I happen to know that at least one of those trainees is in the room with us today. And aside from all of this, Professor Bonham is also a friend and colleague of many of us here at the Berman Institute. Please join me in welcoming.
Thank you. And I am so honored to be here today. This is a really important talk for me, and it's important to be here to honor Professor Haywood. But I want to start by just acknowledging and thanking his family, his mother, and his sister and his niece. And I just want to thank them for all the support that they provide throughout Carlton's life. Whenever he needed support, I know you were there as family for him. And I just want to acknowledge that and the important role that family and caregivers play in individuals with chronic diseases. And Carlton was just so proud of his family. And just so, it's an honor for me that you're here when I am giving this talk. And so just thank you. And I'm just so blessed to have the opportunity to interact with you here today. So I want to just thank the committee for this invitation to give the 2026 Carlton Haywood Jr. Memorial Symposium keynote address. It is a privilege to speak to you today, honor the legacy and the work of my colleague and friend, Dr. Carlton Haywood Jr. I first met Carlton when he was a graduate student, and I was recognized as soon as I met him, the special place that he was going to have within the field of sickle cell disease and as a scholar. Early on, when I met him, we started to collaborate. In one of his first articles, I was a co-author with him as he was looking at and studying issues with regards to pain in sickle cell disease. Dr. Haywood's humility, passion, and commitment to his work and being a good person was evident to everyone who had the opportunity to spend time with him. I don't know a person that knew Carlton that didn't like him and didn't respect him. And that's not something I'd say often about people. Everyone that I met that knew Dr. Haywood found him as a personable, a person with the greatest ethics and a person who had a deep commission for his work. I've dedicated my talk to the use of his doctoral dissertation as a roadmap of his scholarship in advancing the understanding and the ethical constructs of trust and respect. So when I reviewed his dissertation and started reading it, and I said, Carlton is talking to us about where the field of trust needs to go today in 2026. And so I want to just share with you some of the things that I have learned from exploring his dissertation. So Dr. Haywood in his dissertation acknowledged and expresses his commitment to his scholarship and his passion for improving the lives of individuals living with sickle cell disease. He stated, "It is quite clear to me now that all of the experiences, good and bad, that I've had in my own life as a person with sickle cell disease were designed to lead me to where I am today. I pray for the wisdom to accurately identify and properly learn from the lessons of my past and present in future experiences as I continue to move forward with my passion and my mission. And I pray for the strength to keep moving forward despite the obstacles and barriers that I will find in my way." This is from 2008. And if you just think about Dr. Haywood's life and the challenges that he had after 2008 here in Baltimore as he was continuing his scholarship, but also the challenges with his health. And just think about the context of what he was thinking about at that time and thinking about his future and the role that he will play within the field of bioethics and sickle cell disease research. So Dr. Haywood was born in 1976 at the end of a period of mass community education projects across the United States and miseducation with regards to sickle cell disease. It was an interesting period of time where there was a clear interest on how do we communicate, particularly to the Black community, about the importance of screening for sickle cell disease. And there were efforts that were going on with a variety of advocacy organizations and groups across the country. It was an interesting time, but it was also a time of discrimination related to sickle cell disease. There were laws that were put in place by a number of states with regards to restrictions on marriage. There were laws put into place with regards to restrictions related to employment. There was many areas where there were stigma and discrimination against individuals living with disease, but also individuals who were carriers of sickle cell disease or had sickle cell trait. It was an interesting time to think about the history of this disease and its work within our country. But there was some interesting work that was going on during that time by some advocacy groups. And I just want to highlight that the national priorities of the Black Panthers in the United States for their health program was sickle cell disease. And they were involved across the country in screening programs for sickle cell disease. I just want to highlight Alondra Nelson has a great book about the Black Panthers and sickle cell disease. But this issue of exploring, thinking about this condition that has a prevalence in the African American and Black community higher than other communities, and how the community was thinking about how do we address this challenge that our families and our communities have. So it was an interesting time with regards to those efforts. But it was also a time when the first federal funding for sickle cell disease was provided. President Nixon signed into law in 1971 a law that provided for the first sickle cell centers located across the country with $6 million provided in support. But when you look back also, it was an interesting time because of the inequities that have existed with regards to research funding for sickle cell disease versus other chronic diseases and other genetic diseases. And a lot of the comparison work has been between sickle cell disease and cystic fibrosis, where it's clear that the level of support coming from the federal government, the level of support coming from private foundation, and the access to research has been limited in sickle cell disease versus other chronic and rare genetic diseases. Now, things are changing, and clearly over the last decade, there's been significant more funding provided for sickle cell disease, and there are many exciting things happening. But there's an inequity that has existed over decades with regards to research support for sickle cell disease. So this figure from John Tisdale and Suile Thien does a nice job, in my opinion, of just kind of describing where we are for treating sickle cell disease. That we have drug treatments, we have allogeneic transplant, and we now have ex vivo gene therapy. And it is targeted for the future that will have in vivo gene therapy. But when we think about the history of this disease and put it in context, the very first drug that was approved for sickle cell disease was not approved until 1998. 88 years after sickle cell disease was first identified in Western medicine, the first drug, hydroxyurea. But it is a treatment that continues to be used and is helpful to many people, but also it has side effects, and there continues to have health problems for individuals taking hydroxyurea. The first stem cell transplant was in 1984. And this is an interesting story because the young lady, the 8-year-old girl with sickle cell disease, who underwent a transplant from her HLA-matched brother for acute myeloid leukemia, but it also cured her sickle cell disease. And that was the beginning of stem cell transplants. But today, still the number of transplants is fairly low. So, medications, after hydroxyurea, there have been 3 drugs approved by the FDA for sickle cell disease. You see in 2017 and 2019. But one of those was withdrawn in 2024. So there's only 3 FDA-approved drug treatments for sickle cell disease today. So with this context, I want to talk about Professor Haywood's work and the concept of trust and how we think about the framework, the ethical framework of trust with regards to sickle cell disease, and from the perspective of why Carlton's work is so important to us today. But let me just start by saying trust and trustworthiness is having a resurgence in our country. The interest in trust and trustworthiness is coming from a different perspective in different ways. NIH has identified one of its priority interest areas is issues with regards to trust, particularly related to biomedical research. And then we have the Pew Research Center, who's done a number of really great reports about trust and trustworthiness in our country. And it's interesting, and the Pew Research Center has reported that in the last few decades, the share of adults who said most people can be trusted declined from 46% in 1972 to 34% in 2018. So the concept of trust is, I think, important from the perspective of our healthcare and where we are today. But thinking about how does it really fit when you think about a chronic disease or a disease that's been racialized or issues of patient care, and what are some of the important things that we need to be addressing. When you look back over the last decade, the number of articles published about trust have just been really very high. And it's just, there's a lot of discussion about trust. But with the 2008 dissertation and then the body of work that Carlton Haywood was involved in over his academic career, I argue that we need to go back and really explore his work and to take his work and move forward, particularly around sickle cell disease. So Carlton stated, trust is an essential component of the patient-physician relationship because of the vulnerability of the patient and the imbalance of knowledge and power between patients and physicians. Illness inherently places patients at risk, and risk at the very essence of trust. So, Dr. Haywood, going back to his dissertation, going back to his work in 2006, 2007, 2008, really trying to explore and think about these issues of trust, really says a lot with regards to kind of where we are today and what are some of the important issues. And I would argue we need more research grants that are really based on the framework that Professor Haywood and his colleagues established at that time in 2008. Now, over the years, there were a number of articles that Professor Haywood published with colleagues that are here in the room and others about trust, about patient-physician relationships, about discrimination and care, a variety of issues where he was really helping to set a tone with regards to where this work needs to go and really advancing the work. And these publications all have an important context. How do we move forward in 2026 with regards to appropriate research in the area of sickle cell disease research? His work has really kind of set a foundation for bioethics work related to sickle cell disease. When I look back and look at the publications and look at the work that's been done over the last 30 years around sickle cell disease and bioethics, Carlton Haywood's work is the foundation, in my opinion. So, reviewing Dr. Haywood's body of research, and I return to his dissertation, the work of the dissertation in 2008 guides his research and provides a framework of his body of work of trust throughout his career. He states, many definitions of trust abound in literature of various disciplines. One philosopher has defined trust as a way of seeing that guides our attention, colors our perceptions, and thus gives rise to certain beliefs and precludes entertaining other beliefs about the ones trusted. Trust has been described as an optimistic acceptance of a vulnerable situation in which the truster believes that the trustee will care for the truster's interests. Trust is characterized by a sense of security, which screens out negative interpretations of motives and behaviors. Thinking about chronic disease and individuals who have many engagements with the healthcare system, and thinking about the experiences of trust and how that can be altered based on different experiences, I think is an important part of the work that he's done. He said, the greater the risk from illness, the greater the vulnerability, and thus the greater the potential of trust or betrayal of trust within the clinical relationship. Health or personal beliefs which are negatively associated with trust include preferences for autonomy in medical decision-making and patients' preferences for self-care. Higher levels of both are associated with lower levels of trust. This is interesting for me, and I kind of would like to explore that, and I don't know if any of the scholars in the room have done that, to try to understand that better, this issue of autonomy and this question of trust. And I think we need to think about this more, this issue of wanting to take self-control and its relationship with trust in a healthcare setting. And what can we do with regards to that from an intervention perspective, both with regards to patient's trust as well as the relationship with the provider. And so I think that there's a lot here to unravel about how we think about the questions of autonomy and control and its relationship to trust that I would love to see some more work done. Haywood stated, patient trust of physicians is necessary for the ideal patient-physician relationship, and it's an essential indicator of the quality of medical care. Our study of adults with sickle cell disease found that patient ratings of interpersonal skills of medical professionals are associated with patient trust, even after adjustment for potentially confounding patient characteristics. Sickle cell patient trust towards medical professionals should be used as an indicator of healthcare quality for this population. So 2026, how we assess quality of care with regards to individuals living with sickle cell disease, and what are some of the parameters that we need to be looking at to judge that care of both the institutions and the providers in the institution. Our ability to incorporate trust models in that work and assessment of that and how that can help to influence better care and quality of care. I think that there's opportunities for us to take that on as scholars and as health professionals and individuals who are leading healthcare organizations like the great Johns Hopkins. So Carlton also talked about trustworthiness in his work. And he defined trustworthiness has been defined as morally valuable traits of a character, which refers to how worthy a moral agent is of being trusted. And trustworthiness is so important today as we are thinking about our current social environment, political environment, where we are, both from an institutional perspective and individual relationships, and how trustworthiness is so important to really advance and move forward health and advance and move forward our relationships with each other. And so thinking about the trustworthiness gap that exists and what are ways we as professionals, as institutions, can address those challenges. So Carlton in his dissertation talked about some of the determinants related to trust. And he said, I began to appreciate the special moral importance of respect to Blacks living in a society like the United States, which has a history of racial oppression. And further background research led me to consider the importance of respectful treatment for clinicians as a significant determinant of patient trust. I think this is a powerful statement about Carlton and his work and his thinking deeply about this issue of trust in the context of individuals in a racialized society like the United States. And how do we address these issues of understanding that role? He went on to say, patient trust is associated with positive clinical outcomes. High levels of patient trust are associated with greater adherence to medical treatment, greater continuity of care with physicians, greater satisfaction with physicians and in the medical system, better self-reported health status, and greater observance of preventive health measures, due in part to the important clinical outcomes associated with it. Some have called it for the use of patient trust measures as indicators of quality of care. So can we use trust measures in quality of care? I think that's a question that we need to explore. And hopefully my panelists will think about that issue in some of their comments of how can we actually take and make the study of trust and trustworthiness incorporated into assessment of quality clinical care. Can we do that in a way that really can take advantage of those constructs and help to move forward the relationships between the patient and the physician? So Dr. Haywood and his colleagues asserted an agenda for sickle cell disease research that I argue is still important today. First, respect and trust are powerful concepts that integrate diverse strands of research and practice and can be a lever to improve patients' experiences and outcomes of hospital treatment. Second, improving respect and trust in the treatment of sickle cell disease pain should be a priority for healthcare providers, managers, and researchers. And third, collaborative international and interdisciplinary research can help to improve the treatment of sickle cell disease pain by identifying ways to increase respect and trust. So this agenda, I argue, is still important today, was articulated in one of their papers in 2011, but I think it really explored where we are today. So Dr. Haywood in his work really talked about the framing of trust and its relationship to patient-centeredness and ultimately to respect. And when he talked about patient-centeredness, he talked about he thought it's a normative vision of the relationship between clinicians and their patients. And so exploring this issue of patient-centeredness. And in some of the work that was done, and including the work that was in his dissertation, he explored this from an empirical way. And the research articulated that the principal findings from this study is that patient-centeredness of previous care measured as the sickle cell disease patient's rating of the quality of previous medical provider communication and with patients was significantly associated with patient trust toward the medical profession. So taking this from a health services empirical way to really try to explore this relationship related to trust and respect. So his research included an analytic model that really kind of explored his work. So again, this was published in 2008. And then you look at the body of Carlton's work over his career, it's so connected. He just kind of like laid out in his dissertation what he was going to be doing. And, there's a variety of things he did, a number of different areas. But if you go back and say, okay, and look at some of the publications, you see the alignment with regards to what he was thinking originally, with regards to what are some of the issues around trust and interpersonal experiences that needs to be explored. So the patient-centeredness of care is a focus of the normative work that Professor Haywood did. And the importance of that from the perspective of his body of work. And he said, clinician education alone will not be enough to improve the patient-centeredness of care delivered to sickle cell disease patients. Policies must be developed which enhance the characteristics of health systems in which clinicians work in order to promote the climate of patient-centeredness in care. This exploration, if you go back to his dissertation, he talks about policy a lot, actually, of the importance of change of policy ultimately to make a difference. That we must focus in on the relationship between the patient and provider, but that's not enough. And that the policies that are put in place are really an important part of it. So the third area that I want to focus on is respect and the ethical framework of respect. And as I identified in the title of my talk, and as I was going back, going through Carlton's work and just kind of thinking about the issue, he didn't talk about trust alone. He really tied trust to respect, and that this was really tied together in how we think about the importance from an ethical perspective of care of individuals. And he said, respect is an attitude of valuing another person, and it's just demonstrated behaviors that express the attitude. Trust develops in relationships in part due to the presence of respect, and a relationship between healthcare providers and patients respect and trust develop in a process that begins with providers' attitudes toward patients, which are reflected in provider behaviors when interacting with patients. So really exploring respect with regards to the context of trust and patient-centeredness is really important. And he said, I began to see a strong conceptual links between the general obligations of respect and patient-centeredness as discussed in the medical literature. But I found, however, only one article in the literature which previously attempted to provide a conceptual link between these two concepts. Therefore, I sought to provide what I think is a more complete account of the moral link between respect for persons and patient-centeredness. He set up the foundation of his work, identifying this major gap within the field that he could play an important role in his scholarship. And that scholarship is what was done here with many in this room and his leadership that he's provided when he was here at Johns Hopkins. This is a fundamental area that really goes back to the beginning of his career, but goes throughout his body of research. We provide an ethical analysis of disrespect that characterizes the poor interpersonal experiences of care received by persons with sickle cell disease. And we argue for special moral urgency grounded in social justice that should be attached to these experiences of disrespect. His framing around respect, his questions around moral urgency, and that this is really a social justice is a framework for his work. In one of the articles, they really had this nice framework that really kind of talked about the presence of respect and really kind of thinking about really what are the domains that need to be explored in the relationship to create that respect environment, which was important in his work. So respect is under assault when persons or groups are discriminated against. Individuals and groups that are identified with are disrespected, when they are subject of prejudice, when we stereotype people or express a prejudice against them. We fail to recognize their particularity as individuals. We do not give them the proper attention they deserve. We fail to see them for who they truly are as people. These are Carlton's words, where he is articulating what are some of the issues from the perspective of trust that we must be exploring. So, Dr. Haywood's concern about social justice is foundational to his work. And so if you're going to say, well, what was Dr. Haywood focused on? He truly was focused on social justice and his belief of how we can use our study, use bioethics as a way of advancing social justice. He said the lack of respect that frequently characterizes experiences of persons with sickle cell disease seeking healthcare is a concern of social justice. In this way, we seek to illuminate the special moral urgency that should be attached to this issue. So, social justice is a framework of his work. It's exploring the questions about the dimensions of sickle cell disease and trust and respect, where he focused in on appreciating what is important and valuable about a person, understanding the demands or constraints that are placed upon one's own conduct when interacting with a person, and acting in accordance with one's appreciation of the values of a person and one's understanding of the requirements of interacting with the person. So, Professor Haywood, I argue, played a very, very important role in the foundation of bioethics research for sickle cell disease. But he didn't stop with his normative work. And he didn't stop in identifying and framing the problems. He really wanted to move forward to actually make change. So his body of work included interventions, designing and developing interventions to help to make change with regards to the relationships between patients and physicians and individuals with sickle cell disease. And when you think about that body of work of saying, okay, we've identified these issues, we identify the ethical problems, we identify the problems, what can we do to make a difference and change the behaviors? And his work in this area with regards to interventions, I think, was extremely important. And so this work included video-based interventions that could be used to improve attitudes of pediatric providers toward patients with sickle cell disease, the availability of interventions, of varying intensity to provide greater flexibility in design efforts to advance the quality of care. So he did work with regards to pediatricians and providing models to change behavior through video interventions. But he also did some interesting work with adults, where he had patients tell their stories, these normative stories of their life experiences, and in a non-clinical setting to be able to share their experiences and to use that kind of a setting to help to change provider behavior by giving the provider an opportunity to get to know an individual and understand their pains and life experiences, not just when they are in a bed in a episode of pain or in other crisis situations. So really trying to explore this. So these interventions were an opportunity to really to explore these issues and to see if they changed behavior with regards to physicians in the care of their patients. So I'm going to move to my work and talk for a minute about some of my research that I conducted over the last few years at the National Human Genome Research Institute on the issue of institutional trust. And I became very interested in institutional trust and really trying to explore, when we think about trust, that clearly the relationship between the provider and the patient is really important. But we also need to think about the organizations and the role that the organizations play in trust and trustworthiness. So I wanted to assess that issue, and I started this work very early in the pandemic. And really it was exploring the work from the perspective of sickle cell disease patient populations and the experiences of participating in clinical trials for vaccines. And it was a really, if you recall that time period we were living in, where we really had to rely on what we were hearing from government to help us as we're making decisions with regards to our lives and protecting our families and our care, that there was a unique place that organizations and institutions were playing with regards to how we saw the world at that time. And so I was really interested in this from the perspective of adults living with sickle cell disease. So I had a cohort of study participants in a study at NIH with regards to sickle cell disease, where we were exploring a number of different issues. And we reached out to them, and then we reached out nationally to other individuals living with sickle cell disease to find out about their experiences and perceptions about participation in vaccine clinical trials. And we found that the views of individuals living with sickle cell disease are fundamentally tied to their concerns of risk posed by the COVID-19 pandemic, such as worry of infection and disease severity, more than it was solely based on trust and trustworthiness and mistrust. And so this issue of protecting my health was a priority for these individuals as how I make the decision what I'm going to do. And so this framing of thinking about trust from that perspective of protection for a vulnerable population was really an interesting part of our findings. But what we also decided to do with that at that time was to develop a new measure for institutional medical mistrust. So we really wanted to explore this from the perspective of, okay, how can we create a new measure to assess how institutions are trusted or not trusted? So we created the Institutional Medical Mistrust Scale, which we call the IMMS scale, which has 3 domains to it that are assessing mistrust in healthcare institutions, the federal government, and state and local government. And we explored this from the perspective of really trying to understand what trust of these organizations meant. So it was a 7-item measure for each domain, basically the same set of questions, but looking at each domain. And we explored these issues. And this measure was built on a measure that one of your former colleagues here, Professor Thomas Levis, had created that was focused on trust. But we reframed it around institutional mistrust and explored these questions. So this item is a measure that we created to really to explore these questions about institutional mistrust. So I'm going to just share with you one data slide here, but I think it says something important about our society and where we are. So what we found in our national survey, we conducted a national survey with 1,273 participants from across the country. So this is non-sickle cell. This is a general population now that we're looking at, and we did this survey with 1,200 people. And you see here when we think about mistrust, the lowest level of mistrust was with healthcare organizations, followed by state and local government. The highest mistrust was with the federal government. This was in 2022. I would argue today in 2026, and we redo this survey, the gap is going to be significantly even more. So why is this an important conversation to have? Because I think we have to continue to explore these issues of the role of organizations in the lives of individuals and the issue of trust. And that we need to think about the role that each of these organizations play. Now, when we designed this survey, we identified broadly healthcare organizations. But I think that there's some really important work to be done about academic medical centers and measuring their trust and mistrust, and thinking about these issues from the context of these institutions that have research as part of their foundation and how the public perceives them. And how do we address that challenge? So the question of trust is important with regards to the physician-patient relationship, but it's also important as we think about institutions. So Professor Haywood laid out an agenda, and in their Professor Beach and Professor Haywood in their 2011 piece identified 6 areas for the agenda. And I think these 6 areas are important today. International comparative studies, refinement of explanatory models, effects of healthcare policies and structures on patients and provider experiences, developmental and interpersonal processes, applications of social psychology theory, and development and evaluation of interventions to improve respect and trust. I think we have an agenda that continues today. So I'm going to close my talk and talk about to be resilient. And when we think about resilience, Professor Matthews identified Professor Haywood and resilience. I want to come back to that. So resilience means being able to adapt to life setbacks. When you have resilience, you harness the inner strength that helps you rebound from a setback or challenge, such as a chronic disease. Resilience won't make your problems go away, but resilience can help you see past them, find ways to enjoy life, and better handle stress. Dr. Haywood was a resilient man. He was a man that enjoyed many things and pursued his scholarship as a bioethicist. He was not only a person with sickle cell disease that didn't let his disease consume him. He was not the only one. And I want to highlight two men who had sickle cell disease that came before Dr. Haywood. The first man that I would like to identify is patient number one in Western medicine, and I highlight Western medicine with sickle cell disease. Dr. Walter Clement Noel. Dr. Noel was a dental student in Chicago, Illinois, when he became ill, and his blood was examined and described the sickle-shaped red blood cells for the first time. Dr. Noel became a dentist in Chicago and returned home to his country of Grenada, where he practiced dentistry and lived to the age of 31. Think about this. This is a man that was born in 1884 and died in 1916 at the age of 31 as a dentist who had sickle cell disease. That's resilient. He got sick in Chicago, going to dental school. He probably got sick a lot other times while he was in dental school and as a young man. But he continued his life. And he returned to his home and had a dentistry practice until he died. The second person I want to highlight is Dr. Joseph R. Phillips, MD. Dr. Phillips was a professor at Meharry Medical College. He's a psychiatrist at Meharry Medical College, where he taught medical students and had a clinical practice in psychiatry. And in this 1976 Ebony magazine, he talks about how I cope with sickle cell anemia. He was a man who continued his life with sickle cell disease, taught students that went on to be physicians, cared for individual patients, and was a role model. And young people went to see him, to see someone as an adult living with sickle cell disease that was resilient in his life. These are two individuals, too, that were before Carlton. There are others out here that have sickle cell disease that are moving forward to advance their life and their careers. And I think it's important to recognize that because too often we perceive and see individuals through illness. So you can live with a chronic disease and become a leader. Dr. Haywood represents making the most of your life, whatever challenges and barriers may come. Dr. Haywood was proud of the recognition he received as one of the Ebony Power 100, the world's most inspiring people. Carlton was on the list with many people that you know. You can pick out pictures of people you know on that list. And in 2018, he was on that list for Ebony. I'm so proud that I knew Dr. Haywood and called him a colleague and a friend. So, in Carlton's acknowledgement in his dissertation in 2008, he clearly was looking forward to his potential to make an impact on others, and he accomplished that goal. And his lasting words are to all those persons worldwide who are living with sickle cell disease, our day will come. So I want to acknowledge people who helped me in thinking through this talk and supporting me, including my colleagues from my research lab at NIH and former trainees at NIH and colleagues. But I also want to give a special shout out to Taylor Montgomery for helping get me the dissertation that was the foundation of my talk today. And I just want to acknowledge and thank all of Professor Haywood's colleagues that are here in the room for the important work that you guys have done and important scholarly work that now will just be the beginning of where we go from here. And I want to again thank Carlton's mother and sister and niece and to acknowledge them and just thank them. And then I just want to acknowledge all the men and women living with sickle cell disease. There's much work to be done. Carlton has given us a guide and a roadmap, but there's more work to be done. So with that, thank you.
Oh, thank you. What, like, what a treat and a gift to have a tour through Carlton's early work, his dissertation, and to have an opportunity to sort of contextualize it in our current moment with, there's anything we need, it's more trustworthiness and trust. So thank you for that. And I'm delighted to be able to introduce and to welcome up to the table our two panelists. First, Dr. Charity Oyedeji. She's an assistant professor of medicine in the Division of Hematology and senior fellow at the Duke Aging Center at Duke University. She leads innovative research that aims to transform how clinicians care for aging adults with sickle cell disease. Her work focuses on understanding the intersection between sickle cell disease and aging, identifying early signs of functional impairment, and developing targeted interventions to improve quality of life. She developed the first functional assessment of older adults with sickle cell disease called the Sickle Cell Disease Functional Assessment Tool, and the first ever exercise program for older adults with sickle cell disease called Sickle Fit. Her work has been supported by a number of grants and awards, including an NIH Pepper Older Americans Independence Center pilot grant, which provided early funding for the Sickle Cell Disease Functional Assessment Feasibility Study, an American Society of Hematology Training Award, Duke's Research to Advance Healthcare Equity Center Development Award, and the NIA GemStar Award, allowing her to deepen her expertise in geriatrics and health disparities research. Welcome, Dr. Oyedeji. Second, Dr. Roland Thorpe is a professor in the Department of Health, Behavior, and Society here at Johns Hopkins, founding director of the Program of Men's Health Research in the Hopkins Center for Health Disparity Solutions, and is deputy director of that center, and co-director of the Johns Hopkins Alzheimer's Disease Resource Center for Minority Aging Research at the Bloomberg School of Public Health, and inaugural associate vice provost of faculty diversity. A social epidemiologist and gerontologist, Dr. Thorpe's research focuses on how race, socioeconomic status, and segregation influence health and well-being among African Americans, particularly African American men. He's the recipient of numerous awards recognizing his commitment and contributions to mentoring students and faculty, including the Johns Hopkins Bloomberg School of Public Health Advisory, Mentoring, and Teaching Recognition Award, the inaugural 2018 NHLBI OHD Pride Roland J. Thorpe Jr. Mentoring Award, the 2020 Bloomberg School of Public Health Dean's Award of Distinction in Faculty Mentoring, and the 2020 Minority Issues in Gerontology Outstanding Mentorship Award. Dr. Thorpe earned his bachelor's degree in theoretical mathematics from Florida A&M University, a master's degree in statistics, and PhD in clinical epidemiology, and a graduate minor in gerontology from Purdue University. Welcome to our panelists. Dr. Oyedeji, maybe start with you.
Sure. I can assume everyone can hear me.
Yeah.
Hey, this was a great talk. I really, I feel so enlightened. I feel invigorated. So I'm a sickle cell provider. So first and foremost, first and foremost, I am a family member of people with sickle cell disease. My mom lost her first child to sickle cell disease, lost a cousin to sickle cell disease, and also have a lot of family members that are thriving, that are nurse practitioners and respiratory therapists that have sickle cell and that are doing quite well. So I've seen kind of the gambits. I would say first and foremost, I'm a family member of people with sickle cell, but I'm also a doctor for people with sickle cell and a researcher. And I was just very touched, and I really, one of the things that stood out is the importance of having people with sickle cell disease to engage in sickle cell research. And so I was thinking about the statement that you made, or the statement that Dr. Haywood made. The truster believes that the trustee will care for the truster's interest. And so that's really, it really just comes down to, do the researchers, do the providers, do they care about the thing that the patient cares about, right? The patient-centeredness. And one way to do that is to make sure that you get the people that have the condition to be involved in the research themselves as the researchers. And so, on our team, we try to always include like coordinators that have sickle cell, patient advisors. There's community advisory panels that allow us to do that. But as if we can mentor more people to have PhDs and make it easier, have accommodations, because it's not easy. It requires some level of resilience. Kind of like, there are some hard days for people with sickle cell that are doing their doctorate, but trying to find ways to kind of have more of that. Because we see the result when we allow that to happen. And the second thing that I wanted to highlight was just this idea of respect and trust, and really highlighting the communication piece. And so, I was thinking about what you're saying. At first, when I'm thinking about, trust, I'm just thinking about, like, do you trust me as a person? But a lot of this was about, are you sharing knowledge with me, in a way? And so, like, and you mentioned this imbalance of knowledge, and vulnerability of patients. And one thing that I try to practice myself as a physician is, how much can I reduce this imbalance of knowledge, right? I have a lot of knowledge. You're coming into the clinic and you don't know what's going on. How can I reduce this imbalance and give you as much information so that you can make your own decisions, right? And so, and part of that closing of the gap that we don't always do a great job of is deliver that information in a way that makes sense. So finding ways to, like, using technology, using different ways of improving our communication so that people can have more autonomy in the clinic and say, you know what, I have all the information I have, let's make this decision, and so, but yeah, I think this is great. I have a lot of other remarks, but I'll pass it on to my colleague.
Thank you very much. So first of all, I'd like to say thank you to the organizing committee and for allowing me to be here today. And I also want to say thank you to the family. Thank you for allowing and providing Dr. Haywood's work to be personified in a way that oftentimes we don't celebrate people this way. So I want to first say thank you to the family, and second say thank you to the Berman Institute for keeping this on our radar screen and showing us what model to be, what it should be. So thank you so much. When I was listening to, first of all, when I was listening to the presentation by Vence Bonham, I just in transparency, we've been knowing each other. He remembers me when I was a little undergrad running around the Midwest not knowing anything. He did some work on Black men early on, and I got roped in, and I've been doing it since. So to be able to see this presentation was really, really marvelous. One of the things that I took away from the presentation is that Professor Haywood really laid out a roadmap for how, if you want an academic career, how it can be done. For all those who are working on a dissertation and want to go do this business, that was the model that you shared today. And it really is how it should be done. And nestled within that model and how you progress through your career are the elements of trust and trustworthiness, right? You gotta have that trust and trustworthiness and to move forward and the respect to move forward. One thing I wanted to really bring forward, I didn't know this until today, and I knew Professor Haywood. I remember some of the fun times that we had. I got introduced to Professor Haywood through Dr. Janice Booth. She introduced us. She said, "You two need to know one another. Y'all in the same building. Y'all two black men, and y'all the two youngest black men in the building at the time. The others were Dr. Thomas Levis and Dr. Darrell Gaskin. And I had an opportunity. It was a complete joy to meet him. But one thing I didn't know until the day, and I'm really embarrassed about this. I didn't know he was from the crib. I'm from Georgia. I had no idea. I'm from Macon, Georgia. And he's from Atlanta. I had no idea that he was uh, from Georgia. So now, once I saw how you laid it out, it was not surprising the reason why it happened. That's what we do in Georgia. We just represent in a way in which we know how. But I didn't know that. And that actually made me think about a couple things as it relates to trust and trustworthiness and trust in biomedical research. You know, what you were talking about today was, and what Professor Haywood work is contextualized within sickle cell disease. But I argue to you that those same principles can be translated to anything else, any other chronic disease, any other research project that you're trying to engage people in, particularly people who some would argue is hard to recruit. I dispel that myth. They're not hard to recruit. You just don't know how to recruit them. And so until you learn how to recruit them, then they no longer become hard to recruit. And I think a lot of these at the core of what Professor Haywood's whole career about, from my perspective, particularly being applicable to Black men, it's all laid out and all here, right? Where do you find them? You got to build trust. You know, you got to have this shared decision making, particularly in a patient physician encounter. It has to be some level of shared decision making. And that shared decision making just don't start day one. You build this over time, right? And then to be able to build that relationship over time is one of the most beautiful things that I think about. And I think about my relationship with my primary care physician. When I first met her, I didn't trust her, and she certainly probably didn't trust me. By the way, I was her first patient ever, so I know there wasn't any trust. There was nervousness. There was on both sides. No. I didn't trust, but you know what? I built the trust, and as Dr. Bonham was speaking in his presentation, I was reflecting back on some of the things and some of the key points in our relationship, our patient-physician relationship. And those were the biggest thing for me was this trust and respect. And it grew to being able to have a stronger, robust, shared decision-making relationship. And when I got to the point where I was like, yeah, this is clicking, then she left. So now I'm starting over. This is year 3 with a new person, and we're getting there. But I think these things that you articulated, that Carlton articulated through his dissertation, are really applicable things to do, and they're not far-reaching. Some people do dissertations where it's so abstract you can't really see how it can make an impact. But Carlton work is really, really concrete and provide concrete examples of where we can learn from both sides, from a patient side, from a physician side. And the other thing I wanted just to bring forward here is to get at your question is that you wanted is how do we incorporate these assessments into clinical care? I do think we have a roadmap of how to do it. If you think about the social determinants of health, how do they incorporate those of you? And if we follow a model, they're in Epic and MyChart and all those things. So I think we do have a model how to put them into clinical care. The question really becomes is the healthcare system ready for that? That's the conversation that I'm really excited about having. And I'll close by saying your scale, as you briefly showed that your IMMS scale, I saw Professor Haywood work all in that. And I really appreciate that. And I thank you all for allowing me to give just a brief mark. But one of the final thing I'll say to you, Dr. Bonham, is I really appreciate the pictures because it reminded me of the biggest smile that he always had that lights up the room. I'll stop here.
Thank you. I'm trying to figure out how I can make this chair lower so I can come sit next to you because I don't want to be up here.
We can grab one of those chairs. We can get you one of those chairs. Yeah.
So, Professor Bonham, did you want to respond?
No, I know I appreciate those remarks. You know, what I wanted to do with my talk was to portray Carlton, his
Yeah.
voice,
Right.
not my voice. I wanted his voice. I wanted you to hear what he's been thinking and the roadmap that he's provided
Yes.
for more work.
Yes.
You know, I think with your work with individuals who are aging with sickle cell, I think there is so much trust work to be done in that work where I think the foundation that Carlton has provided would be really exciting. And I just think that there's so many opportunities to learn from the work and to build on the work that's been done. And I just think, you know, this is just the beginning. And, you know, I can see him smiling down. Yeah, you guys push it, take it to the next level, is what I would hear him say.
Yeah, I was thinking about some of the pictures that you're showing because, you know, we published a paper last year about perspectives on aging. We interviewed 19 people over the age of 50 with sickle cell disease that grew up, you know, in the 60s
Right.
and 70s, and they talked about the medical system and how it was, and how, you know, a lot of them got diagnosed way later in life, so that already started off the mistrust off the bat, you know, telling them they had rheumatoid arthritis instead of they had sickle cell. You know what I mean? Like, so the misdiagnosis, erosion, the racial discrimination, erosion of, you know, trust, you know, and then when they went to go seek care for, you know, pain, then you had the opioid war on drugs, right? So the war on drugs made it really difficult. And so they had to be resilient, right? They had to figure it out. And so it's not surprising to me why people prefer self-care and self-management, and because they're like, you didn't take care of us properly when I was a kid, you know. So like those, the 50 and up, they really had, and I'm sure, and even younger than that, they had to figure it out. And even to this day, there's a lot, you know, still a lot of people that don't know how to, you know, properly to care for people with sickle cell disease. But yeah, I think it's really difficult to figure out, you know, coming back to this whole metric thing. It's difficult because, you know, to have a measure. The question is, what are the consequences? You know, how do you execute that if someone is not trustworthy? You know, like, what do you do about it, right? Is there some retraining that someone has to go through? And I see, you know, like the intervention that Dr. Haywood did seems to be very effective. And maybe that's something, you know, for people that aren't, you know, trustworthy or not doing well on their surveys, patient surveys, maybe they need to take a course like that. Yeah, it's very challenging though.
So I heard a number of things that, I mean, I completely agree with you, Professor Thorpe, that there's a lot to be learned here that is much more broadly applicable than just sickle cell disease. And I heard from you, you know, nothing about us without us, right?
Yeah.
Which is also sort of much more broadly applicable.
For sure.
I mean, are there other lessons here that sort of those of us who don't work in sickle cell disease should be taking from Carlton's work and the work that's come after it?
So I would just start by agreeing with Dr. Thorpe that his work can be used in all different areas, in all different diseases and different settings. I do think there is something important about his work that's directly related to chronic disease and interfacing on with the healthcare system in many different times and not in isolated situations. So I think that there's just some issues around a individual who has a relationship with the healthcare system that's ongoing, and how trust can be earned and how it can be lost.
Yes.
And the variety of different issues there. So I clearly think there's some unique things, but I think it's a broader area. And, you know, and like I talked about, you know, trust is in as a research area. You know, I actually think I think Carlton's work can really give it some foundation of what are some of the things we need to be exploring. And as you know, as folks go after those NIH grants, so where that's a priority area, I actually think using that foundation will help to advance some work.
Mhm.
I think that one of the things that I wrote down here, I think is really important, I thought was really nuanced, but very important. Carlton's dissertation distinguished between trust and trustworthiness.
Mhm.
And that's nuance. And that's the level of thinking that you want to have.
Mhm.
And you want to take that into the clinical setting, right? I think that's really important. Dr. Bonham, one thing I want to add to what you said, I completely agree, applicable to chronic disease and chronic disease management,
Yes.
right?
Yes.
Right? Because I think it's really important because I need to know that I trust you that when you prescribe me the medication, you need to know that I'm trustworthy to go get it. And not only am I trustworthy to go get it, now I got to be trustworthy to take it and follow it on a regular schedule. I think that's really important. And I think this is the first time that I've read on trust and read Carlton's work on trust because Dr. Levis was doing his mistrust scale at the time. But today it really resonated with me, this nuance between trust and trustworthiness, right? And I think that's really important to be able to distinguish between those. And for Professor Haywood to have that forethought back in 2008 to see it come forward now in 2026 just speaks to his level of thinking and forward thinking and visioning when he was writing his dissertation.
Yeah, I'm thinking about the the intervention, and part of like I said, this is not just a sickle cell thing, but it's basically asking the question: does the provider see the humanity of the patient, right? Like,
Yes.
do you see me as a human being? And this goes not even just patient doctor, right? This goes with any. Do you see me as a human being? Are you going to treat me like a human being? Do you have enough respect for me when you know very little information about me? I'm coming in, maybe I'm not dressed too well today, maybe I'm not at my best or whatever, but are you going to treat me a particular way? And, that goes a lot with, of course, race, right? Like, are you going to, well, especially when there's a racial discordance between the doctor and the patient, whether it be the OBGYN and the Black woman or whatever, we have this dynamic in so many different realms, but yes, this translates everywhere. And so this idea of like having an intervention where you say, okay, let's show the doctors the humanity of the patient. Let me show you this video of them just telling their story, and when they're at their not when they're at their worst, right? Like when they're kind of on a regular day, and so that and it doesn't necessarily have to be an intervention in that cell, but maybe it just shows that the doctor should just get to know the patient, right? Like it's the whole point of doing what it takes to see the humanity and making the effort to see the humanity in the patient before you can properly care for them.
I was very impressed with the sort of the link between respect and trust that he
Right.
made, right? And we're not only in a particular political moment where trust is not at a high point.
Effervescent.
Yeah.
And
Right.
we're moving in the spaces that I work, we're moving towards like more data sharing for broader purposes, and not necessarily with consent, right? And consent was or has been expression of respect,
Mhm.
right? So how do we need to think about, given the link between respect and trust, if we're going to take away that marker of respect, how are we going to replace that to ensure that we're maintaining justifiable trust and trustworthiness of the institutions?
So I think about this a lot. And I think the construct of transparency is so important to this. And the transparency about what you are doing and not doing, so that people that can use that information as they make decisions is important. And is part of what we really need to explore also from a research perspective, and grappling with where we are as a society of data and all the information.
Yeah, I completely agree with that. I think where the wrinkle is the research enterprise is moving so fast nowadays with the technology. You know, data use agreements are bound now, right? But I think it's necessary to create this transparency and so that we can move. But it's really the wrinkle is it's moving so fast, right? And I don't know necessarily how to slow the enterprise down, but I do know that we still have to have things in place to maintain the respect and the transparency of the data, because most of the data that we're getting are voices, and we need to remember there's voices behind, and we should protect and protect those voices to the extent that we can. If it, I've been there myself. If it's I gotta wait 3 weeks to get this done right, and I'm behind on it, I get it. Then I understand it, because then I look at it from the standpoint that those are voices that and when we went to get the data, we assured them that we were going to do everything humanly possible in our power to protect, and I think we should do that. But the worry I have now is that the enterprise is moving really fast, right?
And some of the AI models may not even be doing the data justice, right? Like the bigger the data set, the more the voices kind of get lost in there. So that's something that we kind of have to pair up, the individual voices, and some of these big data models.
Yeah.
So you described Dr. Haywood's work as sort of the foundation here. And I think he's probably the person who taught me this flip from trust to trustworthiness, right? Like it's not about your responsibility to trust me. It's about my responsibility to demonstrate trustworthiness.
Correct.
Right? So I wonder if is there, given your work in this space and beyond, in sickle cell disease and beyond, like have we moved beyond the floor? Have we made progress on some of the markers Dr. Haywood laid out for us?
I would say the answer is yes.
Yeah.
I'm hopeful that there's a new generation of providers who have a different kind of experience and perspective that helps to enhance the quality of care that they're providing. And that, we've moved, but there's a lot of work to be done. I think that's, from my perspective, I think that's also what Carlton was saying, and, and continued to say throughout all of his literature, scholarly work. There's more to be done, but clearly we're not in the 1960s anymore.
Yeah.
I agree.
Yeah. I mean, there's definitely a lot of threats, to take us back, right? To not care about equity and care about these things that matter, right? That data supports. But one of the things that I really, really appreciate, kind of as I was listening to all the quotes, was that, he was able to articulate things that I hear patients say all the time, but they say it at their worst, right? They're saying it and they're trying to scream it, right? And they're like, but they're being interpreted as like, she's crazy, or like whatever, she's whatever. But like the talent of being able to kind of like really wordsmith and really like articulate these really important topics so that people that normally wouldn't receive it, because when someone's in the ED, right, and the patient's trying to tell them this very thing, they're not catching it. They're just like, oh, this person's just but then be able to kind of see it and see the data to support it, and to be able to really build some quantitative data into it, I think that is what helps to kind of promote some of the change that we're seeing too, because not everybody, like I said, cares about the patient voice. They really want to see the numbers. So this was very important work.
Excellent. Maybe now we can open it to the audience for a few questions. Do we have working mics now?
Hi, my name's Olivia. I'm an infectious disease doctor, and I thought this was so fantastic and interesting. Something that I have been concerned about, maybe prevalent in the field of infectious diseases, but maybe throughout medicine, is that we often explain the importance of trust by translating it directly to health outcomes. I think we've made really valuable discoveries that trust is important for promoting good outcomes in health, but I also think we could achieve those same outcomes theoretically through another lever you mentioned, which is control, right? And so we motivate trust with all of the same factors that we could use to motivate control. And then we get worried about trust when we see a breakdown in our control, right? I'm thinking like of the COVID-19 pandemic. All of a sudden, we're concerned about trust because now we've lost control. And so I would just love to hear from the panelists or from anyone else who has thoughts on this. And I think I see some insight into it, obviously, in Carlton's work. Why is trust important other than achieving good health outcomes? Not that that's bad.
I mean, well, I was thinking about, I know we're talking, you're saying other than health outcomes, but, you know, we talk just like how you said with trustworthiness is on both ends, right? Right. We want our patient to also be trustworthy that if we develop this plan, you can't control people when they get home, right? Like you can't control whether or not they're going to take these antihypertensives. And it really makes a difference between life or death. Unfortunately, the health outcomes are kind of an important thing, but it also is their quality of life, right? It's all about their experience and their satisfaction and how they are the experience they're having with the healthcare system, because it is can be a life or death situation if this person is supposed to be taking this, antibiotic and this person doesn't trust you, right? Like, I don't know what you're giving me, doc, like if they don't take it, right? It really, really does come down to not as the only thing, but their ability to trust you. It has to do with what they're going to do, right? They can completely blow you off or not even show up, the subsequent visits, but it's a big thing on the patient end of not trusting you.
So thank you for the question. I'm just going to answer it very directly. Trust is important for human mankind, and trust is important for relationship building. And if you're not trying to build a relationship, any relationship has to have a foundation of trust on it. And once you start that, you can take it outside of health. You take marriage, you take it, friendship, all of it. Trust is important. That's why it's important, right? And you build these relationships, and I think of it in building those relationships, then these other things are parts of it, the greater health outcomes, or the greater health outcomes and the greater justice outcomes, right? Right. So you think about I've written down here injustice of people with sickle cell disease. You think about it. Professor Haywood built trust in the patients that he was representing, and they in turn built trust in him to move the needle. Because you talked about moving the needle forward, and I think he did that. And I think it was beyond just health and health outcomes. Because without trust, we coexist, but do we really move forward in a meaningful way? Did that help you?
Yeah, that's wonderful.
Okay. I totally agree with that.
Right.
Because I was going to say, just as a humanity and as a community, the relationship of people that trust and the trustworthy environment is so important to it as we make through it. But then it's going to actually, I think, continue to help build those relationships that improve health or the economy or just how we interact with others in our world. So I think there are some fundamental issues about mankind that we need to think about.
And really quickly, I think I want to pull this full circle. So I think the ultimate goal of, at least from my perspective, in building this trust, along the way when you're building this trust, you do become resilient because you're in a space or in a community of people who you can, at your worst, they're there to support you, and at your best, they're there to support you. And I think resilience is built also along the way. And I think if you look at the Professor Haywood's dissertation and that research agenda, at each slide as you were going through, that was beautifully orchestrated. I was expecting to see resilience, and you showed me resilience. Well, I said that wrong. Dr. Haywood showed us resilience.
That's right.
Thank you. Thank you. I stand corrected. Thank you. Thank you. Yes.
Any other questions?
Hi, thanks so much. My name is Liz. I'm a psychiatrist that works in the Sickle Cell Center here. I was wondering, you started your talk talking about the different disease-modifying therapies that are out there, and the dearth of them and how some have been removed from the market or are being questioned. And I'm wondering if you could talk about that idea of new therapies and how that fits in with this theme of trust and respect, and how we encourage people to try things that we're not, and then stop trying them because apparently they don't work.
Right. No, I think that there's so much, and I think there's so much work to be done in it from a scholarly perspective. I think there's a lot of work to be done of providing the context of where we are today with regards to new treatments and the challenges and the opportunities of these new treatments, particularly with gene therapy and kind of, where gene therapy is going and stem cell transplant is going. But also the questions around actual disease modifying treatments that are in clinical trials. That there's so much work to understand that. So let me just give one example. So there was an article in Stat last month about Casgevy, which is one of the two gene therapies, the one that modifies fetal hemoglobin, increased fetal hemoglobin from BCL11A modification, and that only like 60 people have gone through the treatments. And so the question is, why so few? What is that about? And so it really gets to this issue of institution and institutional trust. There are institutions that have decided not to use those treatments. Why? What are the issues around that? Can we understand that better? Why those treatments are not available in the state of Maryland? So how can we advance that? Then there's the issues with regards to people understanding what all of the side effects and what can happen with these treatments. So there's a whole area around understanding around these new treatments that there's a body of work that needs to be done. But then there's also just kind of more broadly about why don't we have more disease modifying treatments today? And how do we get to that point? And what does the role that trust, economics, race play into that? I think are all part of the context. And I think that Dr. Haywood's work gives us some direction there.
Yeah, very challenging, especially with the voxelotor coming off market. To have I'm sure you heard the story about voxelotor. Basically, we had an additional drug, right? We had a drug that a lot of patients were on that was helping to boost hemoglobin. And then the drug company had to pull the drug due to some deaths that happened internationally. And so, but we haven't had a full report as to what actually happened. But to have a drug, on them adversity, and we at that time this was our fourth, right? Like I said, this was the Walter Clement Noel. What year was that? 1910. So Magic 4 drugs. I don't know. You work in ID. How many drugs? Y'all got like 1,000. Yeah, that's what I'm saying. I got like 1,000 drugs. Like we got 4. So like it's amazing since 1910. So to pull that drug and people on it, people having to come off. Some people hospitalized, unfortunately, having to make this transition, coming down on their getting their hemoglobin dropped. It's problematic, and I think we have to explain ourselves. Like we have to explain ourselves, especially if we're going to be asking patients to get on more trials that are similar to this. And we know that there were some issues with in some people, not everybody's gene therapy experience was perfect, right? So we once again have to explain ourselves. And so it's about also the providers' trust of these drugs and their ability to explain it to patients in a very transparent and a very open way that these things may go wrong, and patients willing to take risk, right? It's once again this idea of like, am I willing to take this risk? Am I willing to take this risk with you, right? Because maybe I'll take this risk, but maybe not with you because I don't know, So it's really challenging, but like I said, we will try. We'll use some of these frameworks to help us to navigate it for sure.
Well, and you said the drug was pulled 2 years ago, and there's still not been a full report about why. I mean, from a transparency perspective and trust, that's challenging.
Yeah, and there's some reports, but not official publication of what really happened.
And that's a perfect example of why trust is important. outside of health outcomes. That's a perfect example. That's a perfect example. And it reaches further. Think about this. The people who were on the drug, they take the drug. You get a new drug trying to go to market, you got to go through these trials. You got to recruit. You get one of them. Now they don't trust you. So you took it away from me. And how do I know you're not going to do this now? And it becomes increasingly difficult to get people in the trials again. And frankly, most of the people that need to be in the trial look like me. And we need to have a more representation of people in trials that look like me so that we'll have a better understanding of how drugs work and the biology and the makeup for people that look like me. And that's some of the problems we've had for years with biomedical research, the underrepresentation of people of color, people with disabilities. So they're not in these studies. And now when we get to make these generalizations are made for all racial ethnic groups, when in fact you didn't have those racial ethnic groups in it. And if you did, they were so small numbers, you weren't confident of the inferences that can be made from that. So when we think about how this ripple effect is a huge ripple effect that we oftentimes don't talk about in these spaces. And it goes back to trust and trustworthiness, right? It's really, really difficult. Once you break trust, I don't know if y'all realize this, but once you break trust, it's tough to rebuild. Just saying. But it could be really tough, right? And it's a hard sell. Yeah, big time hard sell.
Right. I know we're a little bit over, but we had all our technical difficulties and stuff, and I wanted to make sure we had an opportunity for questions. Any final questions? Yes.
Hi, I'm Meharry Frederick. I'm Carlton's youngest sister. I'm currently taking courses in a doctoral program about teaching and learning, and it was talking about like teacher preparation programs and if we got certain concepts and strategies and whatnot while we were going through our schooling, then maybe right now as we're in the thick of in the classrooms, then we would have a different approach. So I was thinking about that as far as like trust. For those in the medical field, are there like programs when you're going through school? Is there a program around like how do I build trust with my patients? Like, you know,
Yeah. Interpersonal skills for physicians.
There's something like that, but not to the extent that you're probably thinking. But I don't know. Who knows? Maybe at your institution. Maybe.
I'm looking at you, the one that's potential, don't we?
No, but I'm saying that maybe somebody who's having the bioethics background, maybe because I imagine there's no standard here, right? But if you have the advantage of having people like this that are part of the medical school curriculum, maybe or nursing curriculum, whatever curriculum, yes. But not every institution has the benefit of having people that provide, and that's not a priority, right? It's like, can you memorize the Krebs cycle? You know what I mean? Like whatever it is.
Right.
So it's a problem for sure in training.
And I know there is bioethics incorporated into the medical education here at Johns Hopkins, but I don't know how much of it's about trust. And I look to the professors here at the German School of how you guys are integrating within the medical education at Johns Hopkins, one of the leading medical schools in the country, the conversation of trust in a way that the students get it in different ways. So, I think there's opportunities for this to be one institution that's a leader in helping to move that forward, to advance it, to show to other medical schools and other professional schools around the country. Because I do think we need more conversations about it in different ways.
Right.
And there's clearly work that's going on, but whether there could be more ways that it's tied into the education that goes on throughout the 4 years and into residencies in a way that's going to make that doctor a better doctor.
Maybe a call to action is a good place to wrap up.